Let the record reflect that the state's present, defense counsel, and the defendant are all present. We're ready to proceed.
State's ready, Your Honor.
Defense is ready.
All right.
The state calls Dr. Thomas Coyne.
Okay, and I just make sure from the defense there were no other witnesses from the defense.
There's no other witnesses. I just have something to read into the record.
Okay.
Would you rather me do that now?
Yes, I think this is your portion, and then
It is.
does your client wish to address anything in this hearing?
I don't think so.
Okay. All right.
Mr. Wilson nodded his head no. Judge, this is a letter from the adoptive parents of Mr. Wilson. It's been 5 years since the worst of this began. You can't possibly understand how sorry we are for the families affected by this tragedy. We cannot change the past, but we wish we could. On that fateful day 5 years ago, not only were the lives and the dreams of 2 women lost, with their families left behind in shock and grief, but another family was left shocked and grieved over a different kind of loss. It's easy to recognize the victims and their families and to feel profound sympathy for all they suffered and lost. But one group that isn't often recognized as those also suffering is the family of the accused. Our journey of loss didn't happen all in one day as theirs did, but it was heartbreaking nonetheless. Wade was a joyful child, loved his parents and sisters, and was loved immensely in return. But over the teen years, and then especially in the early years of adulthood, Wade began to slip away from us, becoming withdrawn, erratic, and depressed at first. Then, as addiction was added to mental illness, he became frankly paranoid and delusional, and the sense of loss became increasingly sharp. He was in the system for years trying to get help for his mental anguish and for his addiction. They put a tiny Band-Aid on it and then sent him back into the world without a diagnosis, medication, and without follow-up care. We tried to hold the pieces together, but had no idea how to find the support Wade needed to be the person he was inside. The system failed him, and that fateful day in 2019, we lost the last piece of the son we loved and all the hopes for his future. In those tragic moments, when the cancer of severe mental illness and addiction won, we lost our son, grandson, brother, nephew, and uncle. So we understand the despair, anguish, loss, and hatred for someone or something that takes away someone you love. Because despite everything, Wade is still our son, and we love him. The hopes and dreams of his life are already lost, but the human is still in there somewhere, tortured beyond what most of us can even begin to imagine. Taking his life will not bring back those 2 beautiful women. There is no justice on earth for that kind of loss. Taking another life only adds to the tragedy. Please see it in your heart not to kill our son and make our innocent family suffer even more. The system designed to help those who suffer and are lost failed him. That system is broken and would be only further broken if it took Wade's last breath. That broken system owes Kristine, and it owes Diane, and it owes their families, and it owes our family. It owes us all the peace that it did not provide to Wade. Candy and Steve Wilson.
Thank you.
We would rest.
All right.
Judge, I would just ask that you colloquy the defendant to ensure that he doesn't want to speak at this hearing.
Oh, well, Mr. Wilson, you have an opportunity, just like during any of the other phases of, well, let me just finish real quick. Any other phases during the case, if you want to address the court, I would permit you to do that. Obviously, everything's recorded, but you would have that opportunity if you wish. No one can prevent you from addressing the court if you wish to, and no one can make you address the court if you don't want to. So it is a decision that's solely left up to you if you want to address the court or not.
Not today.
Thank
Later, when I come back, I will. Today,
okay.
No, I won't.
Okay.
Okay, thank you.
The state calls Dr. Thomas Coyne.
All right, sir, raise your right hand. You swear affirm testimony you give will be the truth, the whole truth, and nothing but the truth?
I do.
You can take the stand.
May I inquire, Your Honor?
May.
Good morning, sir.
Good morning.
Please state your name for the record.
Sure. Thomas Coyne, C-O-Y-N-E.
Dr. Coyne, did you testify in the guilt phase of this trial regarding the autopsies that you conducted?
I did, yes.
What is your educational background?
Sure, I completed my undergraduate degree at Rutgers University, followed by medical school at Robert Wood Johnson Medical School, which is also at Rutgers University. At that same time, I completed a PhD in toxicology. After medical school, I completed a residency in general pathology or anatomic pathology at the Hospital of the University of Pennsylvania. At that same time, I also completed a fellowship or subspecialty training in neuropathology. And last, I completed a subspecialty training in forensic pathology at the Miami-Dade Medical Examiner Department. And so right now, I'm currently board certified in anatomic pathology, neuropathology, and forensic pathology.
Since we're here discussing the brain, specifically the defendant's brain in this case, would you describe what is neuropathology?
Specifically, it is the study of brain disease in all forms. And so we assess the brain from all ages, from fetal stages through old age. And we look for both normal features as well as all different types of features of disease, ultimately to find out if there was any pathology that may explain why a person died.
Now, when you were a part of this neuropathology program, could you just explain what the practical part of that program entailed?
Sure. There's several different practical components. One area is working directly with surgeons as well as neurologists in a hospital in diagnosing disease in patients who are living. And so we would review a person's most often their biopsies with a comprehensive medical team looking at a person's presentation as well as their clinical findings, radiological findings, and then add in our pathological findings. From a medical examiner perspective, we look at the actual brain in deceased persons. And so my job is to look at the brain to see if there is any underlying disease or injury that may explain why that person died.
Now, how long have you worked as a medical examiner?
Since 2014.
And as part of your duties as a medical examiner, do you conduct autopsies on a regular basis?
I do, yes.
Approximately how many autopsies have you conducted?
Close to 4,000 now.
Now, as part of your autopsies that you perform, are you equipped to examine the brain and determine whether the brain shows any signs of atrophy or any kind of injury?
Yes. Specifically, my neuropathology training allows me to do that.
And in every autopsy, do you examine the brain?
I do, yes. I examine both brains at autopsy, and I also receive brains from offices and other universities throughout the country to examine brain for disease.
And do you testify, or have you testified as an expert specifically just for the brain?
Yes.
And can you just describe that?
I couldn't tell you exactly how many times. I've probably, in my career, testified over 50, but less than 100, and been deposed a number of times as well. In all instances, I'm generally called upon to testify as both a forensic pathologist as well as a neuropathologist, and at times as a toxicologist. But I have been called on probably greater than 25 times specifically just to testify as a neuropathologist.
Now, are you familiar with the field of radiology?
I am, yes.
Could you just explain what radiology is?
Sure. Radiology is very similar to pathology. We're called upon to identify disease or injury, assist other physicians in their management and diagnosis of that disease to further treatment. But specifically radiology, so me, I use my eyes, my hands. I use also the microscope as my tools to examine a tissue. Radiologists from most radiologists don't have that opportunity, so they use various machines which employ either radiation or some form of magnetism to create images of those organs.
And do you believe that the field of radiology, someone who would examine those scans, is that an important field?
Yes, very important.
And is that a field that physicians and other medical professionals rely upon?
Yes.
Now, when a radiologist looks at a film or looks at a scan, is it common for them to issue their opinion?
Yes.
Can you just explain how this process works when a scan is ordered?
Sure. So a physician would order a scan on a patient because they have a concern, obviously, based upon their clinical findings or the patient's presentation. So they would order a directed radiological image, depending upon what system they think is injured. So let's say, for instance, CAT scan of the head versus CAT scan of the chest. And then that radiologist would give their impression, their findings, which basically is just a description of what they're seeing on the imaging. And at the end of that, then they'll give their impression of what they feel is the underlying disease process that is responsible for those imaging findings.
And so, is it safe to say that these doctors and physicians rely greatly on those radiologists' impressions and findings?
Absolutely, yes.
Have you ever seen a situation where someone would order a radiologist not to put their impression or finding on a scan?
Not in my career, no.
Now, one of the things that was brought up was CT scans, and they're essentially, I believe Dr. Rubino testified somewhat that they're fairly useless. Could you describe what a CT scan is and what your opinion is regarding CT scanning?
Sure. CAT scan is very similar to conventional radiography, but the machine takes multiple slices through a person's body, whether it's the torso, the head, the abdomen, the pelvis, or an extremity. And I think Dr. Rubino alluded to that it's the test we order in acute injury. So yes, it's very often ordered emergently because it's very good at picking up acute bleeding. So for instance, in the form of the brain, you can tell right away if a person has a skull fracture, if there is a hemorrhage in one of the various intracranial compartments, or if there is hemorrhage within the brain. But that's not to say that we can't get other information from that particular study. So we can examine brain structure. You can look at the relative growth structure of various brain regions. You can compare one side to the other. You can gain a good opinion as to what may be the underlying pathologic process that would then further direct other imaging or direct the other clinicians to treat.
Now, so if you saw a CT scan that appeared normal with no issues, would it generally be, would new scans or other scans generally be ordered?
Well, in the setting of acute brain injury, you're going to use a CAT scan first and foremost to see, is there a neurosurgical issue here? Is there a bleeding in the skull itself, within the cranium, that would require surgical intervention? Is there anything emergent there? After that is ruled out, let's say, you're looking at the brain structure. If you see no abnormalities, no acute abnormalities, so for instance, let's say you have a mass lesion or a tumor in one part of the brain, that can certainly shift the brain substance from one side to the other. That would clue in somebody that there's something else going on other than hemorrhage there that we have to attend to. But if you see everything appears normal, it would not send that patient on to get further imaging. Because, you know, as physicians, we first do no harm, right? And anytime you order additional tests, it subjects that patient for possible harm or complications of that procedure.
Now, are you able to connect with what you see on a scan and predict behavior simply from looking at a scan?
No, there's no, poor correlation between looking at changes in imaging to predicted behavior. And I think, you know, Dr. Rubino talked a little bit about that with regards to Alzheimer's earlier, and I can speak to it from a pathologist. We certainly know that in patients with Alzheimer's disease, they can have brain degeneration with significant atrophy of the brain. And you can see that atrophy on imaging. And then if that patient dies, I can look at that person's brain and see an enormous number of plaques throughout the brain. But the level of atrophy or the degree of plaques or plaque burden doesn't necessarily correlate with predicted behavior. So I can't say that a person with this amount of atrophy would have, a corresponding amount of cognitive decline. Because there are a lot of inter-individual differences. Each person has their own functional cognitive reserve. A lot of that's based on education, also based on genetics. So the long and the short is, yeah, it's very difficult to predict behavior from looking at a scan or even me looking at the brain itself.
So you would disagree then when Dr. Rubino testified that he could determine the defendant's behavior simply based on the brain scan?
Yes.
Now, another thing that was mentioned was the fact that the defendant had these football injuries and some sports injuries. Are you familiar with CTE?
Very much so, yeah. As a matter of fact, neuropathologists are the only ones that can truly diagnose CTE.
Okay. And can you explain what is CTE?
CTE, or chronic traumatic encephalopathy, is a type of neurodegenerative disease similar to Alzheimer's in the sense that the pathology is based upon the accumulation of tangles known as tau or hyperphosphorylated tau. The interesting thing about CTE, or chronic traumatic encephalopathy, is that what is necessary for the development of the disease is a history of either concussions or subconcussive injury to the brain.
Now, if you were to watch the news, it would appear that every football player who hits their head has CTE. What is the reality of that statement?
That's not true. As a matter of fact, my son plays football. I think the benefit of sport far outweighs those risks. And I say that because the prevalence in society for those with CTE is still quite low, even amongst football players who play recreational sports or at the collegiate level or even at the professional level. It's still around 3%. Which is very similar to other neurodegenerative, or the prevalence of other neurodegenerative diseases. There's a lot of selection bias with regards to CTE. That is because people who have symptoms are generally those who then donate their brain to find out if those symptoms are due to CTE. And more often than not, they find CTE. But overall, no. The prevalence is quite low. We know that there is probably a inherited genetic predisposition to develop CTE, because in about 30% of those who have CTE, they have other comorbid neurodegenerative disease.
And would you expect to see evidence of CTE or some other abnormality such as that on the brain scans that were performed?
You could not necessarily see CTE, but you would see, with regards to chronic brain injury, what you're looking for, because the brain only has a single way really to respond to injury, right? Chronic injury for that matter, looks very similar regardless of what caused those injuries. What we're really looking at is the pattern, the topographical distribution of those injuries, and that really allows you to say, is this consistent with or similar to a pattern we see in CTE or a person who's had repetitive concussive injury?
And looking at those patterns, is that the same analysis you would do for someone with traumatic brain injury?
Yes.
Now, are you also, you mentioned that you have training as a toxicologist.
Yes.
Now, are you familiar then with controlled substances and illegal substances and their effects on people's brains?
Yes.
Could you just briefly describe that?
Sure. I mean, most of your stimulant substances, your psychoactive substances, act primarily through brain receptors or specific brain receptors, mimicking the action of endogenous or normal neurotransmitters. And a lot of the desired effects are because of how it affects our brain.
Okay. Now, would you agree that drugs could affect your ability to think or to plan and to cause you to act impulsively?
Absolutely. Yeah.
And would you agree that people can just do evil acts without having brain injury?
Yes.
Or without having a mental diagnosis?
Yes.
Now, as part of Dr. Rubino's testimony, he prepared a PowerPoint. I'm going to ask you in just a moment to come down. I want to ask you questions about those imaging. He mentioned 2 tests that were not performed. Do you recall which test he referred to that were not performed?
Specifically, he talked about neuroquant, and he talked about CTE with PET scan, looking at radioactive glucose uptake.
Do you believe, based on what you saw in the imaging, that those tests were necessary or important in this case?
No.
And why
in this
not?
case. Well, sure, because neuroquant basically is a computer program that we can use to process imaging, in particular DTI-based imaging, after the imaging is performed, and it's really used to establish a quantitative measure of the volume of a particular brain structure, in particular white matter or white matter tracts in the brain. And really the only clinical or the only indication to do so is if when you're looking at the MRI or looking at the DTI imaging and you actually see differences that would require further quantitation. In this case, there were not any significant differences in the DTI imaging to suggest further assessment with neuroquantification. And the same thing goes for CTE with PET included, because CT with PET, because you're looking to see if there are brain regions that are either hypermetabolic or hypometabolic, and those are usually brain regions that have some underlying pathology or injury. But in this case, these were normal imaging scans without any evidence of pathology that would require further specialized techniques.
We also heard a lot from Dr. Rubino about brain symmetry and the size and the comparison.
Sure.
Could you just talk about brain symmetry, what that is?
Sure. Well, it's just basically looking or comparing one side of the brain to the other. And so I'll tell you with regard to this imaging. Now, just to give you a little background, so I probably look at about 700 to 1,000 brains a year, and I've probably looked easily over 10,000 brains in my career of all different ages. Looking at a brain with my eyes and my hands is very similar to how we look at a brain radiographically. So when a person does a CT or an MRI, they're taking slices from front to the back or top to bottom or side to side through the brain because they can't do it physically on the person, right? Whereas I can physically examine a brain, and I cut the brain the exact same way that a CAT scan or MRI does. So we're looking at the same thing. Our appreciation for brain anatomy is the same. As a matter of fact, an MRI hopes to get to the, one day to the clarity, if you will, or the resolution that I have looking at it with my eyes. That being said, the problem with looking at symmetry on the PowerPoint is that you're looking at one slice. So if I can just give you an example of comparing, especially the ventricles, because the ventricles are hollow structures within the brain. And if you can imagine, let's say, two footballs placed here on the table side by side. We know that a football is conical in shape, right? So if you look at the front of the football, it's going to be smaller. If I put a slice through both footballs, it's going to look smaller. As I move back to the middle of the football, if I put a slice, they're both going to look bigger, right? And that's assuming that I'm making that slice perfectly level with both footballs at the same exact level on the horizontal plane. But let's say if I just angle my knife just a little bit, where I get a little more of the anterior portion on the one on the left and a little more of the middle portion of the one on the right. If I look at that, one is going to look smaller than the other. It doesn't mean that there's true asymmetry. It just means the level at which I'm looking at is not really level. Okay? So you really have to get a volumetric analysis of the entire ventricle and compare one side to the other to truly say whether or not one ventricle is larger than the other. Looking at one single slice can't do it. When you look at the slice that he showed there, you can clearly show that the hemispheres were on different levels. Specifically by looking at the inferior horns of the lateral ventricles, you can tell that they were not level. So to take a measurement of the ventricular size at that particular point was invalid. So it's hard to compare those two.
Thank you. I would ask if Dr. Coyne could step down so
Yes.
I can ask him questions about the imaging.
Okay. Sure.
If we could have the microphone moved over just so we can hear. Dr. Coyne, I want to go through the PowerPoint that Dr. Rubino prepared.
Sure.
And are these the scans that you also reviewed prior to coming here today?
Yes. Yeah.
All right, so let's start with this scan. What do you note about this first scan?
This is a horizontal section through the brain. You're looking here at the ventricles, which look more white, if you will. And what he is claiming that there is asymmetry between these two structures. But by looking at the posterior horns here, you can see the length difference between the two. That's because this is not a complete level section through the brain. You're looking at a different level from the right compared to the left, so you're not comparing the same. So you can't make an accurate measurement here from one side to the other. You're going to get different measurements because of that.
And
So you have to look at the volume of the entirety of the ventricle.
And so based on that, do you believe there's anything significant?
No,
about
and
this?
I'll tell you further why, right? So if you had asymmetry in the ventricles, or let's say, for instance, he also described that there was an abnormality in the size of the ventricles, that they were actually more narrow or smaller. They're not. This is actually appropriate in size. And he suggested that because of that, there's probably due to increased intracranial pressure. But that doesn't happen in isolation. Increased intracranial pressure is going to cause fluid from the ventricles as well as fluid from the vascular space to spill out into the actual brain tissue, and that's going to cause abnormalities in the CSF pattern as well as it's going to cause hyperintensities around vessels. You see none of that here in this actual scan whatsoever. Not to mention, increased intracranial pressure is going to push the brain parenchyma out. The brain is trapped in the skull. It has nowhere to go. So if you increase pressure inside that skull, the brain is going to be pushed outward and downward. And you see no evidence of that at all here. You don't see any evidence. You see the normal sulsation right here or the normal folds of the brain. You have no evidence of that increased intracranial pressure. More importantly, like I said, there's no overt evidence of abnormality in ventricle size, and that matches what the radiologist saw on both the CAT scan and the MRI.
And what was the radiologist's opinion on the MRI?
The MRI was that there was no difference in the size of the ventricles. And that's important too. I know he had mentioned that normally a person wouldn't make comment of that on an acute CT. They very well would make comment of that, because if you see asymmetry on a CAT scan, what it suggests is that there's perhaps some underlying mass process that's pushing or changing the size of that ventricle that needs further evaluation. So a radiologist would certainly make note of that, and a doctor would certainly have to follow up with that.
Now, he also mentioned about the space, made some issue about the space between the skull and the brain. Can you
talked
describe
about, yeah,
that?
sure. So this is a little bit higher up, so I can't really see the temporal lobes here, but you can certainly look at, so here's the frontal lobes of the brain. The orbital frontal lobes are the part of the frontal lobes that curve underneath. And normally when you're comparing the width of the sulci of the orbital frontal lobes, they're going to be a little bit wider than the normal sulci that you're going to see on the lateral frontal lobes, as well as the sulci that you're going to see moving posteriorly to the temporal lobes. So what he's describing here is just the normal spaces between the individual gyri of the brain. And how do I know that? Because the cortical, so if there was atrophy, you would have loss of brain substance. You would have loss of gray matter, and you would have loss of white matter. The cortical size is of normal thickness. There's no loss of cortical size. More importantly, the distance here is all normal. So there's no loss of white matter underneath here. You don't have atrophy in the absence of loss of brain substance. Brain substance is absolutely normal. More importantly, this is all, the white matter from here travels down through the center of the brain into our spinal cord. If you lose substance, you get an increase in size in the ventricles. That's well known, and that's not seen here. So I see no evidence of atrophy at all on this brain. More importantly, when you look at the temporal lobe, he describes changes in the amygdala and the hippocampus. There is no atrophy whatsoever that I can see at all looking at this. More importantly, any atrophy, if there was, certainly I don't think wouldn't have any behavioral readout.
We could go to the next slide, please. What are we looking at here? Is this just more of him trying to say?
This is just, yeah, him using whatever program he has on his computer based on a scale that it has to measure the millimeter size or width of these ventricles. But like I said, look at the differences here between the posterior horns. It shows you that this is not on the same level, so it's slightly off. So you're getting more of an oblique or tangential cut through here, because again, like I said, you're dependent upon a person laying in the MRI tube. Nothing is going to be 100% level. So you really have to look at the entirety of the volume of the ventricle. So look at the volume of the ventricles at multiple levels, not just a single level, and take a measurement and then make an assessment of that. But like I said, if you did have alterations in this, then where is the alterations in the rest of the brain? We don't see that either.
And for the record, you were just referring to slide 3 of Dr. Rubino's PowerPoint. We're going to go to slide 4. What do we see here, doctor?
This is moving more anterior. This is moving more up towards the top here. Again, you're just looking at the white matter, but what we're looking at here, so this would be white matter tracks here. And again, he's talking about these spaces that you see here between the frontal lobe. Again, you could tell that they're at different levels, right? Look at the sulsations different, but more importantly, the white matter pattern is normal. The width of the white matter, I don't see any evidence of atrophy there. More importantly, if you have trauma, let's say we're saying this is due to brain trauma. All right, this is due to a deceleration, acceleration type injury, or direct brain trauma where a person has an impact and then the brain moves both linearly, slamming into the front of the skull and the bottom of the skull, and then rotates about its center axis. And that causes a shear strain to the brain. Number one, it deforms the brain substance. And because the gray matter and the white matter are at different densities, they move at different speeds relative to each other, creating shear strain stress that affects not only the gray matter itself directly, much like if I punch myself in the arm, I'm going to get a bruise. And maybe if I don't get a big bruise, I'll get a little redness or definitely a change. Well, you would see that long term on the brain if you had a significant brain trauma. You would see hyperintensities, calcifications around small vessels. You may even see atrophy. More importantly, you would see an abnormality in the white matter pattern due to that trauma. Or you would see alterations at interface between gray matter and white matter, in particular along the long tracks that cross the hemispheres and go downward into the spinal cord and brainstem. And we don't see any of those changes here.
We can go to the next slide, which is slide number 5. What do you see here, doctor?
This is just, again, another example looking at the ventricles and trying to make an estimate that there are abnormalities in ventricular size. Also, arbitrarily choosing one point versus another point. Again, you can't make an assessment of ventricular symmetry by doing that.
Okay. We'll go on to the next slide, which is slide 6. What do you
Sure, now we're looking more towards the base of the brain. Here's the temporal lobes right here. You're looking into what would be, here's the midbrain right here. And it was probably more pons, actually, midbrain to pons, cerebellum. More importantly, when I look at trauma in the brain of someone that's had significant impact trauma, I'm going to see white matter pathology, very commonly in the cerebellar peduncular white matter that comes from the brain and brainstem into the cerebellum. I don't see any changes of that here, but more importantly, I don't see any atrophy of the parahippocampal region or occipital-temporal region, which houses the amygdala and the hippocampus. So no, I see no evidence of atrophy here at all.
All right, so if we could go on to slide number 7. Doctor, what do we see here? Is this just a further?
Yes, it's just another look at, yep, another level of that same region.
And again, everything appears normal on that slide?
Yeah.
All right, what about slide number 8?
This is actually a great just image looking again. This is now the orbital or the frontal portion of the brain here. And again, this is normal distance or normal spacing between these gyri that you see in this part of the brain. More importantly, as I said, you do not see the atrophy that I normally expect to see when it comes to trauma. The asymmetries that you see here in DTI pattern are quite normal in individuals because there's a functional, there's a functional hemispheric differences in white matter pathways, right? So there are laterality in functions within our brain because of our experiences, things we learn to do throughout our life. There's going to be differences in density of myelination and white matter in our brain, which will present as asymmetry. This pattern here is not something that I would be consistent with traumatic brain injury.
Moving on to the last slide, which is slide 9, Doctor. Is this just another?
Looking a little further backwards, yep.
All right, and again, no abnormalities, nothing here
Yep.
that suggests any kind of brain injury.
Agreed.
Okay, thank you. You can step back up. So, Doctor, based on your review of these scans,
Yeah.
would you have ordered anything further if the
Well,
defendant was your patient?
As a radiologist, or just as a physician for that matter, I would have looked at these instead of normal brain. If I was writing up a brain pathology report based upon this, I would call this a structurally normal adult brain, and I wouldn't be concerned about anything significant to chase after.
Now, another thing Dr. Rubino testified was about lateral asymmetry on the 2023 CT scan that was part of the medical records. Did you have the chance to review that?
Well, yeah, I did see those CAT scans. I know what he's referring to, and he's referring to basically the same asymmetry that we pointed to on the screen there. That is an asymmetry in the lateral ventricles, which were not noticed by the radiologist, and certainly I didn't notice any changes either.
So again, same assessment from 2023 as you've made now. There's no evidence of asymmetry.
Yes, I mean, our brain is not 100% symmetrical. And when you look at one side or the other, you're going to see differences in just the general morphology that you can pick out with your eye. But again, it's really the total volume that matters. And in this case, that wasn't done. It's inappropriate to do one single measurement like that and then generalize to the asymmetry of a ventricle.
Now, the other thing he talked about was the difference in size of ventricles. Could you just explain whether that's significant or not?
So I know that there is certainly a wealth of literature out there looking at ventricular asymmetry and its involvement in psychiatric illness. The problem is that, still to this day, whether you have schizophrenia, bipolar disorder, or other well-known psychiatric illnesses, there isn't a neuroanatomical substrate that allows one to diagnose an underlying psychiatric condition. And so we can try to generalize by saying, well, this brain region is involved, we know that this brain region is involved in these types of behaviors, so therefore if we see a change here, we would expect to have this kind of behavioral abnormality. But that doesn't necessarily always hold true. There's certainly a lot of compensatory changes from one side of the brain to the other. And again, like I said, there's different functional reserves from one person to the next.
And again, based on the CT scans and SMRI, you saw no evidence of any sort of...
I did not see any evidence, and more importantly in this, I didn't see any limbic system atrophy.
Did you see any damage to the amygdala or the hippocampus?
I did not.
Now, the other thing that Dr. Rubino testified.
Just to add one thing, not only just the hippocampus and the amygdala, but the nerve fiber tracts that are important and integrate with that, the fimbria, the fornix, as well as the surrounding white matter.
And those are all normal.
Yep.
Now, we talked about the MOCA test, and I believe it's a one-page assessment. How would you describe the MOCA test?
Well, clearly my patients wouldn't respond well to that because they have no pulse. But what I would say, that's certainly something that someone uses as a upfront, quick assessment. It's certainly not the. I wouldn't base my diagnostic or my diagnoses, on that. It would clue me into what I should do further. In other words, if I'm doing an initial assessment of a patient and I see, hey, there may be a problem here with short-term memory or concentration, then I would do additional neuropsychological testing to really hone in on those abnormalities. A snapshot is a bad thing to make any opinions on, especially in this case because of the setting. We already discussed, and he even alluded to that when he performed the test, that there were guards overlooking Mr. Wilson, that he appeared nervous or anxious. That would certainly, cause an upregulation in your sympathetic nervous system or the activity of our sympathetic nervous system, which antagonizes normal short-term memory. And we can think all of us, if we were taking a test and we had someone looking over our shoulder, we would be much more anxious, and our ability to think through that test would be more difficult. And even you could talk to law enforcement officers who would tell you that, in situations of stress, when your heart rate goes up and it reaches a certain level, your ability to concentrate and think is decreased. So the same thing in this scenario. It's hard to really draw conclusions about one person's short-term memory from a single assessment. Furthermore, same thing with the cranial nerve assessments if a person is shackled or in a setting where they're not able to truly really give a true clinical examination. And lastly, I'll just say, again, reflexes and things of that nature. Sure, a person, Dr. Rubino has been doing this for 20 years, but understand that there is a subjective portion of that too, right? One person's 3+ out of 5 may be another person's 4+ out of 5. So there are inter-individual differences, even in the clinician who's doing who's performing the test.
So you brought up a point that this test is subjective. Would you agree that when a radiologist is reviewing scans, or when you yourself are reviewing scans, you're doing it in an objective way without making some sort of criminal analysis or criminal finding?
Sure. And actually, the first part of the radiologist report, and the same thing with the pathologist report, is going to be the description. You're going to just give an unbiased description of what exactly you are seeing. And then in the impression, you may give your impression as to what you think may be going on. But again, that's from a medical perspective. That's me letting the other clinicians know, hey, this underlying pathological process is probably going on, so you need to do additional tests. But we don't think about it from that perspective.
So when Dr. Rubino testified that he didn't want the radiologist to put his or her opinion of what they saw because they might be wrong, and he's looking at it from a crime point of view. What is that?
I would take affront to that as a pathologist if someone told me not to give a diagnosis on a slide I looked at or tissue I examined, because I had the requisite training to do that. I went to school and did many years learning how to properly interpret that particular test. Another clinician hasn't. And so they shouldn't make an opinion above a radiologist. They should use the radiologist as a consultant to help them guide their clinical decision making. But they don't have the capacity to make a better decision than a radiologist does. That's my clinical opinion.
Now, going back to the MOCA, I got sidetracked a little bit when we were talking about subjective versus objective opinions. But would you agree that the MOCA is simply just a screening device?
Yes.
And so it's not actually considered a diagnostic.
It's one of the many tools that you would use in formulating a clinical picture.
Now, would you agree that a lot of different testing that a physician might perform or a psychologist might perform, that there are certain standards or certain requirements in order to perform that test?
Yeah, and every test that we do, yeah.
And what is the purpose of being properly certified to administer a test?
Well, it's reliability, number one. I mean, you want to make sure that you are appropriately administering the correct test in its correct form, so the answers that you elicit can be, actually examined, right, and utilized. And then you need to have some sort of inter-test reliability that your test is being performed the same way somebody else would be performing the test. Therefore, you can compare your answers or your results to somebody else. And that's the only way you can truthfully arrive at a diagnosis that can then be, approached with treatment.
So would you agree that in order to administer a test based on testing requirements and testing standards, that person should be administered and how to give that test?
They should be, yeah.
Now, Dr. Rubino testified about essentially his opinion was based on the MOCA failure in conjunction with the MRI. Again, did you see anything, when he says in conjunction with the MRI, was there anything significant about the MRI that would suggest?
Several things I'll point out. I mean, I know he saw the MRI findings and he made the assumption that there was atrophy of the frontal lobes as well as the anterior temporal lobes, which I did not see any evidence thereof. Furthermore, the radiologist didn't see any evidence thereof. And he made the assessment that that was due to a history of trauma or chronic traumatic injury. But looking at those brain scans, I can clearly see that there is no evidence that I can find of traumatic or the patterns that one would expect to see in chronic traumatic brain injury. Furthermore, he goes on to talk about the hippocampus and the amygdala, which those being in the limbic center were somewhat atrophic and therefore can be used to explain perhaps a person's impulsivity. But I did not see any changes there in the amygdala or hippocampus to support that suggestion. Going on even to the cranial nerve exams, I know he had mentioned the the jerk nystagmus, the horizontal jerk nystagmus, as well as the cogwheel rigidity. I think he had looked at or said earlier that was somehow supported in the MRI, but we're talking about brainstem function here, specifically nigrostriatal extrapyramidal motor system, which he said, sometimes we see in Parkinsonism, and that's true. That's more ventral midbrain, and we saw the picture of the midbrain in there. And that's not something that I would see specifically in trauma. In other words, if forces are directed towards the brainstem, I'm not going to only see injury to the midbrain, I'm going to see injury as well as to the pons and medulla, which are structures that are continuous with that. I'm also going to see it in the white matter structures that are communicating with that structure, and we see no evidence thereof. More, if you do see extrapyramidal motor system defects, I could argue more importantly that it may be very well related to hypoxia or even drug use because certainly increased dopamine signaling in that part of the brain we know is associated with toxicity. Dopamine itself can be toxic. Dopamine, the metabolism of dopamine by our brain produces semiquinone radicals. It produces oxidative stress, leads to damage to that part of the brain. More importantly, hypoxia can as well. We know people who survive cyanide poisoning have Parkinsonism-type behavioral characteristics afterwards. And that's again because that region is more susceptible to hypoxia, more importantly, reperfusion. So let's say if you had an episode where you stopped breathing or were on drugs, let's say, opiates and breathing very slowly and then suddenly restored function, that reperfusion there could produce injury to that brain region. And that would be more consistent with the findings on cranial nerve exam than trauma because I don't see any other associated findings or even imaging findings that would lead me to believe trauma caused that.
So as far as the brain scans, they're not consistent with that finding?
Yes, that's correct.
And I know you already talked about reviewing that CT scan from 2023. Defense referred to that incident as head trauma, but was there in fact any evidence of head trauma?
He was, no. And so certainly from an acute perspective, no evidence of trauma to either the head, the skull, the brain's coverings or the brain, and certainly did not see features that would make one think or suggest that chronic brain trauma was present.
Okay. And again, atrophy would have been reported on that CT scan had it been observed?
Yes, especially because of the presentation of the patient at that point in time. You're trying to figure out what's causing this patient's underlying condition. If there was a period of hypoxia related to, let's say, drug usage, that would be very important.
And was he in fact hospitalized for overdosing in the jail on fentanyl?
That is what I had read in the records.
Now, looking at that scan in 2023, would you have ordered any additional testing based on the radiologist's findings or based on your review?
Based on the radiologist findings, no. I would have looked elsewhere. In other words, I would have determined from that point in time there was nothing for me to be concerned at within the skull.
Now, another thing we heard about today is these self-reports that the defendant gave of being in car accidents and sports injuries. Did you find any actual evidence of those things or those incidents?
If there was a significant head injury, impact trauma, leading to either subarachnoid bleeding, which is bleeding on the thin coverings that are immediately surround our brain, and would make sense, right? If you're in a car accident, your head slams into, let's say, a windshield, your brain's also moving at that same speed and will slam into the skull. And that will can produce a bruise on the brain itself, so you would see hemorrhage in the brain tissue, but you may also see a tearing of the tissues that surround the brain, causing subarachnoid hemorrhage or subdural hemorrhage. I know it's a long explanation, but the point is that I saw no evidence there of that having happened.
Okay, and going back to those injuries, though, would you agree that those are all just self-reported, that you never saw any medical records or admissions records or anything to support that he had, in fact, been injured?
I would agree, because looking at the imaging, I wouldn't predict that there had been significant prior brain trauma.
So, based on all of your review of the records, based on the review of the scans, based on hearing and looking at Dr. Rubino's report, let me just quickly, before I actually ask you that final question, was Dr. Rubino's report, believing that he had traumatic brain injury, issued prior to any scans?
No. Not that I know of. I mean, so his report, I only became aware of it yesterday, but his report, I believe, was based upon the results of scans that were performed prior. That's what you're asking. I'm not too sure. I'm sorry.
So when Dr. Rubino issued a report, I believe the state sent to you, and in that report he ordered new brain scans.
Okay, yeah.
So that report where he concluded he believed that there was some sort of brain trauma, was that conclusion then before we actually had those new scans?
I believe that conclusion was based upon his assessment of him physically.
So not including those scans. It
not
was
including
just his
those scans, yeah.
physical assessment.
Yeah, that's my belief.
He believed it was
yeah.
traumatic brain injury, ordered the scans, and then that supported
Yes,
this.
because he had the history from the patient telling him about this history of trauma. He did the cognitive assessment as well as the assessment of motor skills, made the assumption that there was underlying brain trauma, and then had the scans performed.
Doctor, do you believe it's appropriate to make a diagnosis of traumatic brain injury before seeing any current scans?
Not a diagnosis. You keep it in what we have a differential diagnosis, or a working list of potential diagnoses based upon a person's history as well as their presentation, their clinical presentation. And so you make a list of possible things that can go wrong. And obviously, brain injury is in one of those categories of dysfunction, right? You think about prior ischemic injury. Ischemic meaning lack of blood flow to an area of the brain. Not necessarily a stroke. A stroke could be one of the causes, but you think of mass lesions, you think of, for instance, prior drug overdoses or exposures, and you put trauma on that list, but you don't make a definitive diagnosis. You have a working list, then you use your other modalities to sort of narrow that down. Hey, I'm looking at these imaging here. Do any of the patterns here suggest one of those diagnoses? And certainly the patterns that you normally expect to see in traumatic injury were not present in those images.
So now, final question. Based on Dr. Rubino's testimony here today, based on your review of the medical records, based on your review of the MRI and the CT scans, what is your ultimate opinion as far as whether the defendant suffers from any kind of brain trauma or brain injury?
I saw no evidence that there was any underlying structural abnormality to the brain that would be consistent with chronic brain trauma. So I would say no. To me, it looked like a structurally normal brain.
No further questions. The state tenders a witness.
All right.
Good morning, how are you?
As I recall from the last time you were here, you're the chief medical examiner, Panama City?
Tallahassee, yeah, District 2.
Okay. And you're still doing that?
Yes.
How long have you been there?
I've been there since May 1st.
Your presentation today is based on, seems to be based, tell me if I'm right or wrong, on Dr. Rubino saying, well, there is traumatic brain injury. Is that your conclusion?
No, I looked at the CAT scans and the MRI without forming, as I always do, before I form an opinion upon, even on my autopsy cases or cases that I perform a neuropathology examination on, I do not like looking at the history before I do an examination because I do not want to be biased as to what I am seeing. I then go back and I look at the actual history or what we think may have happened in a person's past to see if I'm seeing any features that would agree with that. But in this particular case, no. I looked at the brain scans and looked at the brain scans just like I would look at an actual brain, and I made my diagnoses and compared them to what Dr. Rubino had said, and then looked back to see if I could figure out what he was referring or how he arose at those conclusions, and I didn't agree with those.
You didn't agree that there was the atrophy?
That's true. Yes, because again, atrophy doesn't occur in isolation, right? So atrophy has to happen for a reason.
Just
Yeah.
what is atrophy?
Sure. Atrophy just generally refers to shrinkage, right? So loss of normal size. When we're talking about the brain, atrophy refers to loss of substance or brain tissue, in particular the neurons that make up that's the sort of the most important unit of the brain are the neurons and then the associated nerve fibers.
As you get older, doesn't your brain shrink naturally?
Not naturally, pathologically, but yes, it will atrophy, yeah.
All right. Well, on those images that you just looked at, in the frontal region, there are dark areas. Is that part of the atrophy?
No, you're looking at different T1 and T2 images. So dark, normally fat lights up when you go to T2. Water and fat will light up, and so you're looking at just the different types of MRI images. But there wasn't any abnormal white matter pattern that I can see. But more importantly, it isn't just so. If you have a dark area, you have to have a corresponding. Which, if you're saying that a dark area of the brain is due to loss of tissue, well, then you also have change in the tissue around it, right? So, in other words, tissue gets lost, infarct, trauma, what have you. There's hemorrhage, inflammation, and then you have scarring. And so you have a change in the morphology of the tissue around it. The tissue in this brain was normal. There was no atrophy, abnormal change in the gyri, so there was nothing that I could see that I would attribute to atrophy.
If, I think that image was taken last week, August 21st, I think. If Mr. Wilson had suffered traumatic brain injury, and I'm not sure how you level that.
Sure.
But, I mean, not everything is a complete blow to the
Yeah.
brain. But if he did suffer that, and it could regrow, regenerate,
Well,
fix itself?
the brain doesn't regrow. The brain has a very limited capacity to regrow, at least with regards to the nerve cells or the neurons, right? So ultimately, the central nervous system, when we have injury or loss of nerve cells, you have replacement of that by scar tissue, and the scar tissue in the brain is called gliosis, or the astrocytes fill in that void. that tissue never regenerates. There are areas of the brain that have stem cells, but they really do not contribute to reorganization of the brain following injury. So when you have injury and loss of tissue, it's essentially gone forever.
But that doesn't necessarily mean that there's a impairment. I mean, the brain works around the injury, right?
Impairment with regards to what? Are you saying to when the original injury occurs?
Correct.
So when you have a concussive injury, let's say, really is injury to the white matter of the brain, right? And when you have a concussion, you don't have to have cell death or loss of those neurons, right? You can have a disruption of the cytoskeletal elements on the inside of those nerve fibers. And that disruption of the normal cytoskeletal elements causes abnormal flux of ions, swelling of that nerve fiber, and therefore the normal electrical signal that would move from the top of the cell to the bottom of the cell is disrupted, right, if not impeded. And so while that process is repairing, it's not regenerating, it's just slowly going back to normal. And that can take weeks to months. The cell then is returned to its normal state, but the cell itself doesn't die. So therefore, you're not actually losing and regenerating a cell. You're just allowing for the normal repair process to occur. You're allowing for the inflammation to subside. Now, if the injury is severe enough, you would lose cell tissue, and that's irreversibly lost. It really comes down to the amount and level of tissue. Let's say he did have trauma to his brain and he did have concussive injury with loss of tissue. It's not significant enough for me or anyone really to see here on this imaging technique. You know, you're probably going to have to look even microscopically or use really, really sensitive techniques. But even so, if it's severe enough to produce abnormal function, you should see it on the imaging.
The claims of pre-existing injury, they were quite some time ago.
Sure.
Okay. Now, what happens if you have pre-existing injury and you add FLACA to the mix? Let me ask you, what is FLACA?
Well, it's that very similar to the sort of novel psychoactive stimulants. It's sort of, they have somewhat stimulatory as well as hallucinogenic effects in the brain.
And or cocaine, let's say. What effect would those have if you've got pre-existing, minor, not necessarily traumatic, but...
Well, it's very hard to predict because it really depends upon what structures of the brain are injured and where there's minor trauma. Because cocaine, is going to cause a massive alteration in brain dopamine, right? And so that's primarily going to affect, your with respect to cocaine, limbic system, perhaps
Excuse me, I apologize. What's limbic system?
Oh, sure. Those are the structures of our brain that include the hippocampus as well as the amygdala, the mesiotemporal cortex, structures of the brain that are interconnected there, and they really are involved in our emotions, our emotional learning, as well as short-term memory formation. Those structures are involved in taking our environment and sending on short-term memory to become long-term memory. But to answer your question about drugs and their effects, drugs will have adverse effects on a normal brain, right? It really comes down to not so much brain structure as it works at the molecular level, right? People that have our drug metabolism enzymes play a role. Our drug receptors and how well that drug can bind to a receptor and activate that nerve. So it goes much deeper than that. But drugs themselves can have, you can't predict how prior brain trauma would affect the effects of a drug. It really comes down to what areas of the brain are injured.
So in other words, nobody knows what the effect of drugs
Yes, it would really be on an individual basis, and there's so many variables there. It'd be hard for me to answer that.
Thank you. I have one moment, Judge?
You may.
I assume some of this, but I'll ask you.
Sure.
Have you ever met Mr. Wilson
No, I
other
have
than in
not.
court?
No, I have not.
Have you conducted any testing on Mr. Wilson?
No, I have not.
Did you review, other than what you've testified to from Dr. Rubino, did you review testimony of any other professional witnesses?
I did not.
You reviewed the test results, or at least the imaging from Dr. Rubino?
I reviewed the images that he reviewed also, as well as the medical records that had the radiologist review. I heard and I read what Dr. Rubino said about it from his deposition.
Okay. Did you ever review the MRI of Mr. Wilson?
I reviewed, yeah, all those images.
Okay. And there were what, 8 images?
There were several imaging studies that were performed, yeah. I can't recall the exact number, but yeah.
Did you prepare, from what you reviewed, did you prepare any images, presentation to support your testimony?
No, I just, my knowledge and my knowledge of the literature and my experience.
Are you aware of any psychiatric or neuropsychological diagnoses in this case?
In this particular case, no, I did not review those reports.
And you're not qualified to controvert diagnosis by either Dr. Rubino or the radiologist?
Well, when it comes down to looking at brain structure, absolutely I can. That's my job.
Okay. Now, if Mr. Wilson is impulsive based on the addition of cocaine or flocka to the mix, or he's unable to recognize implications from his conduct, are you saying that, in your opinion, the MRI does not support that, the MRI images?
Well, so take a step back. How cocaine or any of those, psychoactive drugs can affect a person. Certainly we know that they can phenocopy all of the positive and negative symptoms that we see in schizophrenia, as well as the psychoses that we see in bipolar disorder. Within that realm of behavioral activity, one would expect to see agitation, impulsivity, and other abnormal behaviors while under the influence of those drugs. That those do not correlate with having to have abnormal imaging findings. That can occur in a structurally normal brain. It has to do with the effects of the drug interacting with our brain receptors.
So you can have
So you can have a normal brain and still exhibit those behaviors. And I didn't see any changes on his brain that would be anything that would deviate significantly from normal.
Thank you, Judge. Thank you.
Thank you very much.
All right. Anything else? All right, sir, you can sit down.
Thank you.
Any other witnesses from the state? No. All right. So any other witnesses or any other evidence of any mitigating circumstances under Spencer that the defense would like to have the court consider at this time?
I just have some argument.
Okay.
You want to do that now, or you want to do that at sentencing?
If you want to present argument now, and I'll give you an opportunity to address the court again at sentencing, you can do both, or choose whichever you would like.
I'd rather do it at sentencing because of something that my client said when you inquired of him, I need to talk to him.
Okay. Very well, so you'd rather wait until this afternoon?
I would.
Okay. All right, then. At this time, then, we'll be in recess until 2 o'clock this afternoon, and see you then.